All right, so we're in week 8. Only a couple more weeks left to go. So keep on pushing forward. You guys are doing great. Um, I am just looking at attendance real quick. All right. Um, how is everybody doing with your group projects? Everybody good?
Yeah.
Okay. So just want to reiterate, um, for the group project. It is a PowerPoint, right? So no minimum sides, no maximum sides, none of that, but it is it is a PowerPoint presentation. Everybody needs to submit the PowerPoint in the Dropbox under the assignment. Um, so for the where it says, I'm trying to see the exact, it says leadership group project. Um, It's the one that has 100 points assigned to it. Make sure everybody, once the final project is all put together, that everybody submits. You all are going to submit the same project. So just make sure that everybody puts it up there. So no questions. Everybody is good with that? Yes. Okay. Um, All right. So again, we're in week 8. We have one more exam. And so there's the reviews are already starting. You haven't had a chance to attend a review. The recordings are posted for you, so you have access to the recordings. Um, and then of course all the times and days are all listed in your announcements as well. Um, I was going to say something else too, and it just slipped out of my head. Um, if you want to schedule a time to go over any of the concepts, please send me an email so we can meet. Don't want anybody going into exam 3 with now a good understanding of the concepts. Trying to think of what else. Make sure you get all the rest of your homework turned in. Remediation times for HESI have also been posted, so you have those. After the exam next week, we will have our HESI review. Excuse me. So we'll take the exam, come back, we'll do a HESI review. Those HESI review recordings will also be posted. So you'll have those as well. Haley, Janika, Rashida, I cannot see faces. Ivana, I can't see faces. LaShonda, all I see is your forehead. If you guys can fix your camera, that would be awesome. Janika, all I see is your forehead. LaShonda, all I see is your forehead. You guys can adjust your cameras. That would be awesome. Um, so this week we are going to talk about nursing theory, research, and evidence-based practice. So in your Success in Practical Nursing book, it is chapter 13. In your concepts book, it is concept number 47. And then in your nursing delegation and management of care, it is chapter 18, which is evidence-based practice. So this information is going to be on your exam. And so after we go through lecture, we have a case study. And then if we have any additional time, we will also do some practice questions. All right, so I will share my screen. All right, so again, chapter 13 in your success book, concept 47 in your concepts book and chapter 18 in your evidence or in your delegation and management of care text. So tell me, what is nursing theory? What is nursing theory?
AdPi.
AdPi, okay. What else?
And it's also looking at the client as a human, but in a holistic view. So not just treating them for their signs and symptoms, but also putting into play their mass list, which can also include psychosocial support.
Okay. All right. So give me an example of a nursing theorist. Everybody should know at least one.
Our nursing theorist, Nightingale, Florence
There you go.
Nightingale.
I was going to say
I'm like,
everybody should
how did
know at least one nursing theorist. So yes, so Nightingale, absolutely. All right. So there are a bunch of nursing theories. Okay. So there are a bunch of nursing theorists that are out there. And some, why do we have nursing theories? So there's lots of good reasons for nursing theories, and a lot of them too are even the basis for curriculum development. So how nursing schools um, establish their curriculum and what's the theory behind the nursing curriculum. But there's three concepts that are important to nursing. These should be, we should all understand them. It's the person, who is the recipient of the care. It is health, which is obviously the goal of nursing, right? We want everybody to get back to a healthy state or a previous level of health. And then we have the environment, and that's the setting where nursing care takes place, right? And nursing care, as we've discussed previously, can take place in a numerous, right, varieties of settings. And so we have to understand nursing theory. And if you're going to go back to school and get your RN, you're going to you'll even dive deeper down into nursing theory. So most BSN programs will have like a nursing theory course where you will learn all about all those wonderful theories. But yes, Florence Nightingale, and everybody should know who Florence is. And so she is considered the um, first nursing theorist. She was back in 1860 during her, I don't even know what to say, her practice, I guess, during the Crimean War. She was the first one to emphasize the environment, ventilation, warmth, noise, light, and cleanliness, especially, right? Maybe we should wash our hands in between seeing our clients. If we give them good food and we give them light and we, make sure they have fresh air, right? And that all of the what are the all the research, I guess you could say, that she did during that time when she was there, she improved the care of those soldiers that were wounded, and the morbidity and the mortality rate significantly dropped. She felt strongly too that environmental issues influence the course of illness, right? Obviously, right? If, what happens if we're not washing our hands or we're not, providing for a safe environment, right? That's going to cause issues with our clients, right? So we're spreading bacteria, viruses, germs from one person to another. But again, she initially was a statistician. So she was able to go in there with a fresh set of eyes. She looked at all of the um, statistics as far as, the morbidity and the mortality. And then she made some significant changes to the care of those soldiers that were wounded. Everybody should know who Abraham Maslow is as well. He was a psychologist. Okay, so he was not a nurse. However, um, his human needs theory was adapted by, a lot of programs and especially nursing programs as a framework for education. Okay, so his theory states that there are certain internal, external, physical, and psychological needs that are common to all people. The needs are arranged in a hierarchy, right? So you have that nice little pyramid, right, that you can see when you look at Maslow's hierarchy. Unmet needs create tension, which motivates the person to meet the need. Okay. So when we look at the bottom of Maslow's hierarchy, and we look at those basic needs, right? Oxygenation, nutrition, elimination, safety. I forget what else is on there. Rest and comfort, hygiene, activity, and then even your sexual procreation. Those are all basic needs that every human has. If we are unable to meet those needs, that is what creates the tension, right? We need to at least strive to obtain those needs. When we have those needs that are met, they're no longer aware that those, needs need to be met because they are met. And the need no longer motivates him or her, right? If I'm breathing, if I'm eating, if I'm safe, if I'm getting rest and I'm able to shower and, have my hygiene, my activity, right? And that's just a normal part, and I'm not struggling to meet those needs, right? It's not going to motivate me. The dominant needs that matter to a person can vary in life, right? And this is just like with anything, right? What, was important when I was younger maybe isn't as important as I get older, right? Or, some of the things that weren't so important when I was younger are now important to me as I get older, right? So again, that unmet need is going to create tension to motivate people to react to meet those needs. Another really important theorist was Dorothea Orem. And she had her self-care deficit theory. And there's three sub-theories that fall under Dorothea's or Orem's theory. So first one is self-care. All right. The this involves a goal that is directed towards a safer environment for life, health, and well-being. So ideally here, individuals learn to respond to health cues in themselves or within the environment as a way to maintain personal health, right? So whatever, right? It's a safe environment. And we have a self-care deficit. Self-care deficit um, the personal care doesn't meet the therapeutic self-care demands. Okay, so for whatever reason, that person is not recognizing, or maybe they don't know what to do in a specific health situation, right? So they have a self-care deficit. And then the nursing system. So nurses empower the client through their interpersonal relationship to help meet their self-care demands. So we react, right, holistically, right? So we support that person, in all aspects. When we look at this, anybody that comes into the healthcare system has a self-care deficit, right? Doesn't matter the reason why they are, seeking healthcare. They are in a healthcare, self-care deficit, right? They don't know how to, get themselves back to a previous state of health. Her theory is concerned with things like growth and development needs, as well as the physiological and the psychological needs. So when we're, gathering data or using that data collection step of that nursing process to identify specific self-care deficits, right? And so again, working with those clients, we're going to develop that set of interventions, right? So that we can meet the goals that are set by both the client and ourselves or as nurses. Madeline Leninger, she had her cultural care theory. And so within this, she was just curious. She wanted to learn about different cultures, and how nurses respond to people with different cultures. And so she recognized there was a link to understanding care based on cultural background, right? So we know that culture plays a huge part, in how we care for our clients. And so we have to incorporate that into the plan of care. She said that there were two kinds of care in every culture. So we had generic and we have professional care. So generic meaning is like, the home remedies that people use in care. And we know a lot of cultures, right, use home remedies. And then the professional care, and that's provided by people who are specifically trained to provide that care. And then there's three modes to guide nursing decisions when providing care. So we have cultural care preservation or maintenance, cultural care accommodation or negotiation, and cultural care repatterning or restructuring. Okay, so when we look at preservation or maintenance of cultural care, this is, assisting that person, or family to maintain their care values, and so, like I said, or we try to incorporate, right, those cultural values within their care. So, still allowing them to use those cultural practices that they're comfortable with, as or in conjunction with the medical care that they are experiencing. Accommodation or negotiation again, right? Um, we just want to make sure that the practices that they're using are safe and effective, and maybe even sometimes just showing them the correct way to use things, or then repattering or restructuring. So we know not all practices are potentially safe, okay, and so when we look at certain practices, we don't want, if we think that it's potentially dangerous, okay, then we want to either, provide the education as to why it's potentially dangerous, and then maybe offer a solution, right? If they're going to absolutely want to do this practice, what is another way that we can make it a little bit safer for our clients? Hildegard Peplau, she developed her interpersonal relations theory. This was the basis for developing our therapeutic relationship with our clients. And so there are certain parameters, right? And that it is a major part of the treatment. We know that we need to build that therapeutic relationship with our clients. So there's four overlapping phases of her interpersonal relations theory. So think of orientation. The client is seeking care because of a felt need. Okay, so they have identified that there is an issue, okay, an illness, an injury, maybe even a psychological issue. Okay, so they recognize that this is a problem and they seek care. So the nurse is going to work with them to help them recognize the problem. And a lot of times there's lots of growth that occurs during that orientation phase. Identification is where the client then understands what's going on, understands that situation, and responds to the nurse who supplies the needed help, right? So we can apply this to any patient that comes into our care when we're looking at developing that therapeutic relationship. Helping them recognize that, what the issue is, and then they are going to respond to the care that they are receiving. And then we have the exploitation. I don't like the term for that, but um, we have the exploitation. And this is where the client starts to depend on the nurse and is using the help that is offered. So, whatever, if it's an illness, an injury, right, they are accepting the care that is being offered by the nurse. And then we have our resolution. So this is now that client's dependent behavior on the nurse, right? We have to give that up, right? Whether they're being discharged, or the relationship is ending because they no longer, there's not a dependent need now. And so this is where that therapeutic relationship starts to come to an end. Again, maybe they're being discharged, transferred, whichever. Um, and how the nurse handles this is crucial, because we want to make sure that they have all of the information that they need. Um, all right. Then we have Rosenstock. Um, all right. So Rosenstock's health belief theory. Um, Erwin Rosenstock developed her health belief theory that tries to explain why or why not a person will take action to prevent or detect illness. Um, so perceptions, they vary. Um, they may not have no basis in reality. So, for example, I'm trying to remember the exact. So with your book size. So they came in, oh, so a person came into the emergency room, I think they said because they couldn't sit down. And then during the assessment or during the care, it was determined they had advanced cancer of their vulva. Okay, so the client was shy, and even though they were aware of the changes, they hoped it would just kind of go away. And so um, you know, the thought of being examined embarrassed the client because nobody has ever looked at that. So we have to understand that, not everybody has the same perceptions when it comes to their healthcare. The second one is beliefs are connected to existing barriers. Okay, so um, think about, the cost of healthcare. If somebody doesn't have health insurance, right, then the preventive care may be expensive. It could even be painful, or even inconvenient. Okay, so when we look at existing barriers, if we try to remove as many barriers as possible, then we might get better results, right? Um, we know, especially with preventive care, we want to catch things early, right? The earlier we find things and we begin to treat, then, um, we also, we know that it's more beneficial for those clients. Then acute action is seen as necessary. Okay, so what are some additional ways that we can um, encourage someone to participate in prevention measures or even going to the doctor for like annual visits and things like that? So things that could potentially, I'm trying to think of a good word, encourage someone to see a doctor, right? So whether it's, getting a call from the doctor's office, hey, haven't been in for a while for your, your checkup or your blood work or something, or it's time for your annual mammogram or your prostate exam, whatever it is, right? So sometimes those um, little reminders are something, right, that help to, cue them, hey, maybe I really should go, get my annual checkup. Um, or sometimes a cue to action would be something even less intense. It could be that they're in pain. Of course, nobody wants to be in pain. It's not something that we enjoy doing. So that would cause somebody, right, to seek healthcare. I'm trying to think of what else, or seeing something on the news, and we maybe well the news, but even commercials have been helpful. If you look at some of the commercials out there, they're bringing a lot more notice to certain conditions like hypertension and even some of your liver diseases, diabetes, right? So they see these, advertisements or commercials on TV and they're like, maybe that could be me, right? Or I can relate to that. So we want to make sure, um, we're trying to encourage people, right, for those preventive cares. So the theory also with Rosenstock, we can use that when we use the nursing process to promote health as well. And that's why I was saying, like, your yearly exams, vaccines are also part of your prevention, even wellness classes. These also should be included in our nursing process, right? To remind people that these things are necessary. Then we have Sister Calista Roy, and she has her adaptation model. So she describes the recipient of care or the client as a holistic adaptive system, right? And we teach holistic care, right? When we care for our patients, right? It's everything about that patient. We know that it's not just an illness, right? The illness, yes, affects the patient, but we have to take the whole patient into consideration, right? What is their psychosocial, their socioeconomic status, right? All of that is part of it. So both internal and external stimuli affect this, affect the system, right? You have a patient that comes in, they just had a heart attack, it just doesn't affect that patient, right? It affects, their family. Maybe they're the breadwinner of the family. And now they're missing work. They don't know how long they're going to be out of work, right? They don't know how they're going to pay their bills, right? So we know that that external stimuli affect them as a whole as well. So she identifies that there are stimuli. So focal stimuli is something direct, so such as a client experiencing pain. We have contextual, meaning other factors that affect the local stimuli. So being examined in the area of pain. So, right, go in, say I broke my finger, right? And I go in to the doctor's office because I broke my finger, right? So I go for pain. And in the process, right, they're going to feel my finger and they're going to examine my finger, which then could cause area or pain in that area. The residual is referring to the internal and external factors that may or may not be always evident, right? So that could be having a memory of pain, right? And how that previous pain had an effect on that person. Coping mechanisms and Sister Roy's. um, theory, we have a regulator and we have a cognator, right? So those are the two coping methods or subsystems that she describes. A regulator system is the internal effects that take place in response to what is happening internally. So this is all the like your nervous system, it's your chemicals, it's your endocrine process, right? So think about, I'll just use pain as an example again, right? With acute pain, generally acute pain is that sudden onset, right? It is going to cause sympathetic nervous system stimulation, right? And what happens with sympathetic nervous system stimulation? What happens with our body? If I were to start yelling at you, I'm just
Fight
kidding.
or flight.
Fight
Chris,
or flight.
Right, you got your fight or flight. So tell me what happens with fight or flight.
It's kind of like a panic mode.
Okay, so what happens to my vital signs?
Everything goes
they
up.
Yeah,
increase.
thing goes
Everything
up.
goes up.
Okay, so my heart rate, my pulse, my respiratory rate are all going to increase, right, with acute pain, right? And that, so we know that that's going to change our vital signs. So that's kind of chemical and endocrine, right? So what are the endocrine mediators of fight or flight? Which chemicals cause that increase in my pulse and my blood pressure and my respiratory rate?
Is it
Adrenaline.
your hormones?
Yeah, my hormones, epinephrine and norepinephrine, right? So those are what are triggered, right, when that fight or flight kicks in, right? So, you know, that's all that internal stuff, right? And even when that occurs, my body is still going to try to regulate that, right? So we're going to try to bring that down. We can't stay in that fight or flight for a long period of time. Okay, but that's what the regulator subsystem is. It's all the physiological stuff that goes on. The cognator substance, this is the learning, the processing, the judging, the emotion that the client uses to cope with what has happened, right? So, um, let's say I'm driving down the road and a squirrel runs out in front of the car and you slam on your brakes, right? That fight or flight is going to kick in. Most of us, right? It scares the daylights out of us. Um, right. And then how do we process that, right? And most of us will, have to calm down a little bit, right? We process what just happened. Um, but this can be true for anything. It could be for an illness, it could be for an injury. So again, the regulator, that's the physiological, the internal effects that take place. And then the cognator, right? How do we adjust? How do we process that whatever has just happened to us? And then we have Watson. So Jean Watson, she's really famous theorist as well. Um, she had the theory of human care. All right. So according to Watson, health is harmony among the body, the mind, and the spirit. It also involves self-perception and how the self is experienced. All right. So when we look at illness is a lack of harmony within the self and the soul. And that nursing role as a caring process to help client regain harmony and health. So through the caring, and that therapeutic relationship that we establish with our clients, right? They develop self-knowledge as well as self-healing. And so the enabling actions of the nurse allow that client to solve problems and to grow, and both the nurse and the client will grow during this process. Now, there's only a few theorists that were listed here, right? So we talked about, of course, Florence, and Abraham Maslow. We talked about Orem and Leninger and Peplau. We talked about Rosenstock, Roy, and Gene Watson. Now, I'm here to tell you there are a lot more nursing theorists out there. Um, and, as you go through school, you will learn about, if you continue on with your education, um, you will continue to learn about nursing theorists. And if you're interested, I think it's the site that I always go to when I'm looking at theorists is nursingtheory.org. And it's got all of the different theorists and some information about each of them are there. It's just interesting. I know a lot of people don't think theory is all that great, but some of these theories and how they develop their theories is actually really interesting. And we use a lot of these theories as a basis to providing care, curriculum development is also another one. But there's lots of good theories and, kind of learning the different ins and outs. We use all of these in healthcare, as, you're going through and you're developing your relationships and things with your clients. You're using bits and pieces of these theories, whether you realize it or not, right? Because, um, you've been taught them in school and that's how we teach them, right? So the different things that we teach you, right, are all backed by theory. So you're using the theories. You may not realize that you're using the theories, but you're using the theories. Um, and then we have nursing research. So we look at research, right? Everybody, all of those theorists, right? They did research as they started to develop, right, their nursing theories. But it doesn't matter what level you are in nursing. Um, Everyone is encouraged to participate and promote nursing research. So with that, nursing research identifies specific nursing interventions that are proven effective, not really based on tradition. So think about that, right? You may hear the term, well, we've always done it that way. That's kind of why we're doing it this way now, right? Or other things like why do we turn and reposition patients every 2 hours, right? How do we know that that's effective? Or why are some procedures done sterilely and others are done using a clean technique, right? What's the basis for that, right? So research, right, has shown if we, do this procedure sterilely, it decreases the chances of infection or whatever it is. So it's not merely based on tradition. There's been research behind the things that we do and why we do them the way that we do. It also provides evidence that support the quality and cost effectiveness of what we do, as well as generating knowledge for clinical practice, education, and delivery of nursing services, right? So you've heard the term evidence-based practice, I'm sure numerous times throughout your nursing education, and nurses do research, just like, researchers do research in a variety of different subjects. Hence, we have the whole, Institute for Nursing Research. We have two main types of research studies that are used in nursing that are done that are done in nursing. We have quantitative and we have qualitative. All right. So quantitative, these are objective. Okay, they're objective studies. And so a variable is the event that the researcher is trying to measure. And there are two different types of variables. We have one variable that is the group receiving the intervention, And then another variable is the group that does not receive the intervention. So I'm going to apply this to, let's say, nursing education. All right. So we'll take a group of students, we split them up into two groups. All right. And without telling one group from the other. All right, we'll offer, let's say, extra tutoring to one group and the other group doesn't get extra tutoring. Okay, and then we're going to look at the results. And how do we look at the results, right? And give them an exam, see which group does better, right? Or you can take medications because, taken pharmacology. So, look at how we develop new drugs, right? So we'll take two groups of people. And let's say we're trying out a new hypertensive medication. All right. So we got two groups of people. One group is going to get the new medication for the hypertension. So that's receiving the intervention. Then we have another group that is maybe they're just going to continue on with whatever treatment that they are receiving. They're not getting the new drug. And then what are we going to do? We are going to look at the results of both of those, right? Who's did they, are they doing, is the patients with the new antihypertensive medication, what's going on with them, comparing to the group that have just the current treatment, and we're going to compare results. A randomized control trial, that is the recommended type of quantitative research. All right. So again, it's, the same thing. One variable receives the intervention, the other does not, and we compare the results. The why it's objective is because we're looking at, more objective information. The second type is your qualitative. Qualitative research studies are subjective research studies. Okay, so we gather this information by interviews or even direct observations. It's a narrative description of the lived experience of individuals. So you can take a group of people that, like the example says here, that live with chronic pain. All right. So you take this group of people that have chronic pain, and we have a list of interview questions that we are going to ask each one of these people. All right. And then we're going to record their answers. Now we can look for patterns, but for the most part, it's subjective, right? We can't really measure anything because everybody is going to give a different answer. When we look at phenomenology, this is also a type of qualitative study. And so here it says a case study examining the lived experiences of high school students who are both gifted and diagnosed with ADHD. Okay. So they're going to take kids that are diagnosed with ADHD who are also gifted. And we're going to interview them, right? And get their experiences. Again, it's completely subjective. And so there's methodologies, there's questions, there's all sorts of things. But when they write out this research study, they will literally put quotes from the patients or for whoever the study members were within their qualitative reports. Whereas with a quantitative report, you're going to get a bunch of numbers and, comparisons and things like that. So again, quantitative, that's objective. We usually can have something tangible to look back on, whereas qualitative is going to be mostly subjective. All right, I'm going to stop. Anybody have any questions?
No, I don't.
Nope, we're good so far. All right. So then that's going to bring us to our evidence-based practice. And I know everybody has heard of the term evidence-based practice. So Dr. Archie Cochrane, he was a British epidemiologist. He challenged the public to pay only for medical care that was proven to be effective. And he advocated for the use of randomized control trials, right? Those quantitative studies as a means of reliably informing healthcare practices. And so forget what year it was, but the Cochrane collaboration was established. It was a not-for-profit organization. And it was there to promote the accessibility of the Cochrane reviews. And those were just a collection of evidence-based healthcare interventions obtained by systematic reviews of research. So what does that mean? So all of those studies, right? So whatever it is that you want to ask, why is it done this way? Why is it done that way? Um, they'll take and do a systematic review. So they'll look at a whole bunch of research studies that were done, and they will evaluate those researches, and they will determine, okay, what the best evidence-based practice is. All right, based off of the results of doing research. So in 1999, this was life-changing. So in 1999, the Institute of Medicine issued the report To Err is Human, Building a Safer Health System, which discussed the incidence of medical errors in healthcare and the need for reform. Okay. So I don't remember the exact amount, but it was like, oh my gosh, how many? It was in the millions. Um, it broke down what they averaged was the number of people that were affected by medical errors in the United States. Now, many of the errors, not gonna lie, were medication related. But it's also things like, wrong site surgeries, right? And other errors that occurred in the healthcare system. So they wrote this whole big report. And then in 2001, they issued Crossing the Quality Chasm, a new health system for the 21st century, calling for consistent, high quality health care for all people. Included was patients should receive care based on the best available scientific knowledge. So they took this information from that 1999 report and they made a bunch of changes in practice. Okay. So things like, and I don't know, in the hospitals that I was going to when I was doing clinicals, it was still there. So Pyxis machines, like you go into a hospital, right? The Pyxis machine has its own medication room, right? Um, there's sometimes there's signs over the Pyxis machine. One facility that we went to, it had like yellow caution tape on the floor in front of the Pyxis machine. And basically what that meant was, if the nurse was in the, um, within the yellow box, right, pulling their medications, that they weren't to be disturbed, right? They did start doing like the surgery timeouts, right? You're going in for a procedure and they do like a surgery timeout, like, okay, who's the patient? What's the procedure? Who's, any allergies, any of those things. Um, yeah. And so they put all these practices into place. And then I can't remember the year. I don't remember if it was 2009 or 2019. They did a follow-up study to the 1999 report. And even with all the changes and implementation things that they had put into place, there was still not a significant drop in the number of medical errors. And it's kind of crazy if you ask me. I was reading something not like last week I think it was. Um, a patient had to go in for surgery. They had to have their spleen removed, I think, or something, and then ended up getting their liver removed. Like it was just insane. Like, there's still errors, you still hear. There was another one. This was probably, I mean, a little bit longer ago. I don't remember exactly how long ago. Patient went in for kidney surgery, and because I had to have one of their kidneys removed. Can't remember what was wrong with the kidney. And the doctor removed the wrong kidney. So the diseased kidney was still in place, but the good kidney was removed. So unfortunately, then I've like, even having like the wrong foot amputated. So unfortunately, these errors still occur. And so this is one of the reasons why we preach safety as much as we do, right? Always making sure that we're providing that safe, effective care. Um, and one of the big shifts is right here. During the last 2 decades, insurance companies began to pay for healthcare practices only if the effectiveness is supported by scientific evidence. Okay, so if you're going to perform a procedure, give a medication, do a treatment, whatever it is, it needs to be supported by scientific evidence. And during the last decade, so within the last 10 years, hospitals are denied payment when complications in Medicare client develop if evidence-based guidelines are not followed. Okay. So one is, I think I said this, I'm not sure if I did, but there's like I said, I think I said this early in a previous class. It's about the quality of the care that we are providing, not the quantity. Okay, you can go in a client's room 100 times a day, but if that client is not receiving quality care, if that client is not satisfied with their care, then guess what? They're not going to get payment. This is the same thing when we were talking about with healthcare reimbursement, right? If your patient develops a ventilator assisted pneumonia or a catheter associated UTI or what else is out there, any kind of infection, pressure area, that is not providing quality care. And insurance is not going to reimburse the hospital for the care for that particular reason. So you have a client that comes in, let's say they had a stroke. All right. They're getting reimbursed for the care of that client due to that client's stroke, right? And let's say that client develops a pressure area, okay? Um, the care for that pressure area is not going to be reimbursed because we did not provide quality care to that patient, okay? For whatever reason. Was it not, using pressure relieving? Was it not turning and repositioning? Was it not making sure that they had effective diet, whatever the cause may be, um, that hospital is not going to get reimbursed for the care of that pressure area. Same thing if we put a Foley catheter in and that patient develops catheter associated urinary tract infection. Okay, we have to treat it, the hospital has to treat it, right? But they're not going to get reimbursed for the treatment of that associated UTI. So this is a huge push. And this is with like us, like I said, within the last 10 years, this has become an even greater push. Clients and families are seeking the latest evidence on websites about the most effective treatment for illnesses and diseases. A lot of people most people, no, I'm not going to say all because not everybody does, but most people have access to the internet. Okay. They're going to Google, what are the best treatment options for whatever disease, whatever illness it is. they're going to Google and they're going to, look to see what are the best options and they're going to push, right? So a lot more people are becoming a lot more health literate, right? They're doing their own research. Um, and so, that's not a bad thing. Absolutely not, right? We want clients, we want them to be involved in their own care, right? We just need to, as nurses, make sure that they are looking at um, the correct website, right? Um, you can find just about anything you're looking for on the internet, good, bad, or ugly. But we want them to use evidence-based practices. We want them to know what the current evidence is, right? So rather than going to a .com, right, we want them to go to a .org. We want them to go to an edu site, right? Somewhere that we know that they are going to get accurate information. So before we go into how we determine what is the practice guidelines, right now, I'm going to stop again. Does anybody have any questions? All right, let's go ahead and take a break. Let's be back at 3:10. All right. So now we're going to look at how best evidence for practice guidelines is determined. Okay, so it is a rigorous process, right? It's not something that is going to happen overnight. All right. Um, so the first thing is the clinical question being investigated is formatted in an objective, concise manner. Okay, so what are we trying to find? And that's basically what it is. Okay, so, what is the clinical question that we are trying to answer? Okay, and it could be anything. It could be, think about, why why do we insert a Foley catheter using sterile technique, right? So that could be a potential, clinical question that we are trying to ask. Um, then we're going to find the best evidence to answer the question. So we're going to use professional resources, the latest, most relevant, um, research evidence that pertains to the clinical question that we are trying to ask. Okay. And so when we look at that, that is where you're going to go into like your online library. And you're going to, type in keywords and you're going to do research on inserting Foley catheters using sterile technique. Okay. And so there's a variety. There's PubMed, there's CINAHL, there's the Cochrane review that we were talking about earlier. There's what is it? The Agency for Healthcare Research and Quality. There's the Joanna Briggs Institute. Again, we want to look for the most relevant research. And usually we're looking at like the last 5 years, okay? And then once we have all of that, we've done all that research, made sure that the research that we have is credible, then an expert or a panel of expert is going to conduct what we call a systematic review. So they're going to look at all of the selected studies that we obtained within, our literature review. And from that point, then they're going to write a summary. Okay. So they're just going to write a summary of all the selected studies that we chose. And then we're going to determine the guidelines. Okay. So those are going to be the practice recommendations that we have received from looking at those research studies or those research articles. And then using critical thinking skills, the evidence that we get is going to be combined with, our clinical experience as well as client preferences and values for use in a specific clinical, situation. So another one, maybe we're looking for, I don't know, best practices for post-stroke care, okay? Because maybe we have a patient that came in and just had a stroke and, we're looking at those best practices. So again, we're going to do using those resources, we're going to find a whole bunch of information about post-stroke care, okay? Do that systemic review, and then we're going to develop guidelines. Okay. So we're going to take all the evidence that we got. We're going to, combine it with clinical experience and what are the client's preferences for care. Okay. And then we're going to use those specific interventions to treat that client. Other elements of evidence-based practice. So this is kind of what I just said, right? We're going to take the research evidence, the nurse's clinical experience, and the client's preferences all together. So it's going to look like a nice little, you can have a nice little chart. You can put it in a nice little triangle. You can put it in a circle, however you want to do it. So again, it's the best practices or the best research evidence, the nurse's clinical experience, and those client preferences. and that's going to provide our evidence-based practice, right? That quality client care, which is the goal of our nursing. So what do nurses do? So this is always interesting, okay? We link up the nurse's role. So nurses do research, right? We have the National Institute of Nursing Research, right? So we know that nurses do research. So nurses with a research doctorate, which is like your PhDs, okay, they design and implement research studies and they will publish their findings. Okay, that is, one of the things that um they are going to do. Your nurses with a practice doctorate, they review present research and they formulate evidence-based protocols. So, like for example, myself, I am in school to get my DNP, which is a Doctor of Nursing practice. Okay, so mine is a practice doctorate. Okay, so for my project, okay, I review present research and I have my own clinical question, or I guess clinical question, it's not really a clinical question, but I'll have my own question that I am trying to answer. Okay, so based off of the research that I am completing. At the master's level, okay, they can formulate research questions. They can evaluate the effect of evidence-based solutions on nursing problems. At the bachelor's level, they can identify questions that need to be studied. They can critique published works. They can use evidence and solutions as solutions to nursing problems. At your associates or your diploma program levels, they challenge the status quo, they question assumptions, they offer new insights to improve the quality of care. And practical vocational nurses, again, they question the basis for nursing actions by considering research evidence, tradition, and client preferences. And so I think I've said this before. You guys are, you're bringing in fresh set of eyes into the nursing workforce, okay? So, this is, someone brand new coming into the nursing workforce. You may um, see things that maybe, could be done better, offer insight into some of these things, and even recommend changes in practice. Does not mean that you won't have to do research, because you will have to do the research. But that is, like I said, it's one of the key things is coming in with a fresh set of eyes. You can, make recommendations for changes, and that's absolutely fine. They want you to do that. They challenge you to do that as new nurses coming in. So again, question the basis for nursing actions, do research. Um, look at the evidence, look at tradition, look at what your client preferences are, review articles, even when you go out into practice, okay, remember that, it's never completely over, okay? Your education is never completely over. You're always going to continue to learn. And so take some of those what's some of the status quo, and see if we could potentially find better ways to do things, and do your research, present it. As students and graduates, there are protocols and procedures, right, for nursing interventions of the agency in which you practice. But again, go start going through articles and you start to see that, maybe there are some things that, could be changed or done better, then that is your, part of what you can do. A lot of places that you'll work at, especially hospitals, they have some sort of a library. And when I was, working on the campus, and discussing with like some of the nurse managers and things, A lot of times the librarians will be there to assist you. So if there's like something that you're specifically looking for, or you can't find something, they are there to assist. So that is something that you will have access to as well. But always look to see if you can make changes, right? We want to try to make, whatever evidence is saying, we want to, evidence is saying, sorry, we want to use the best practice, right? Then, is it more cost efficient? Is it more time efficient, right? Those are all potential areas for improvement. And that's that spirit of inquiry, right? Always ask why. A nurse that has a spirit of inquiry is, who's is someone that's going to raise questions, they're going to challenge the traditional and existing practices, and also seeks creative approaches to problems. And there's lots of needs for this. And so, we can even just discuss like fall prevention in the elderly, okay? We have traditional methods that we use for fall prevention, absolutely, right? Um, and so we also know that, not always 100% effective. So go and do research, right? What are some of the potential, best practices for, fall prevention, or even start to think outside the box? One of the, and we look at rate, can't even talk. When we look at how do we develop an answerable question? And this is, has anybody heard of a PICO question before? Anybody heard the term PICO question before? So PICO questions it's a framework for formulating that evidence-based question, okay? So what it is we're trying to research or look up or whatever it is. So P is for population, I is for intervention, C is for comparison, I is for intervention, no, comparison intervention, sorry. And then O is for outcome, and then T is for time, right? So when we look at population, what's the population? All right. So like I was saying, elderly adult, older adults, um, in a long-term care setting, right? That would be the population. And then the intervention, right? So describe the intervention, or whatever it is that you're interested in. And so just like a nursing intervention, right? You want to describe whether, it's a new fall prevention, strategy. And then your comparison intervention. So what are alternative interventions? Okay. So you need something that you can compare. No, I stopped sharing because this is just coming from my head. It's not coming from the PowerPoint. Um, so the comparison, so let's say I'm just going to use something that we um like one of the fall prevention measures is toileting every 2 hours, right? So we would compare that with another intervention that could potentially be used. And then we're going to see if it works, and that would be the outcome. So, what is the outcome that we are looking for or we are trying to avoid? So in this situation, if we're trying to implement a new fall precaution, right, then we want to have a decrease in falls or no falls at all. And what time frame, right? Is this something that we, can do short term, or is this a long-term measure? And that's just going to depend on your on your institution where you're at. If you're in a hospital, it would have to be more of a short-term intervention, right? Because we only usually see patients for a short period of time. But if you're in a long-term care facility, right, then your intervention may take a little bit longer, right? So we may have a little bit more time to evaluate that intervention. But PICO questions, they are, again, they're one of the ways that we can use to develop that question that we are looking for answers to. All right, so we're going to do a quick review. All right, so we have nursing theories. Again, numerous nursing theories. If you're really interested and you have a little bit of extra time, you can go to nursingtheories.org. Okay, and that's going to give you a bunch of the nursing theorists. And again, some of these are also the basis for curriculum development. But the three concepts, what are the three concepts for theories that are important to nursing? When we talked about nursing theories, we mentioned three concepts that are important to nursing. What were the three concepts?
Personal health and environment.
Very good. Person, health, and environment, right? Those are the three concepts that are important to nursing. So again, Florence, right? She was you know, the first nursing theorist. And so, she again during the Crimean War, she looked at the numbers, a whole bunch of people were dying. And so she collected data and evidence, and then she made her clinical decisions based off of that, right? So clean air, food, decreased noise, light, cleanliness, right? Those were essential to patient care and decreasing the morbidity and mortality. All right, tell me about Abraham Maslow's. So we have the needs. They are arranged in a hierarchy. All right. And what happens? What
If
are the, yeah,
if the lowest need can't be met, then the rest of the higher needs can't be met.
good job. Yes. So our goal as humans, right, is to meet those basic needs, right? Those basic needs are always going to be first, right? Nutrition, elimination, rest, hygiene, activity, oxygenation. Those are the basic needs that every human has, right? And so if we are not able to meet any of our needs, it's going to create tension and it's going to motivate us to try to meet those needs. Okay. So we meet the needs of one level, we can move on to meet the needs on the next level. All right. When the needs are met, right, they are no longer aware that the need is now, is there. So it doesn't motivate them, right? But they are continually trying to move up, right, in that hierarchy. Um, we had Dorothea Orum's self-care deficit theory, right? She had the three sub theories: self-care deficit, and the nursing system, right? So self-care is the ability for us, it's a goal that is directed towards a safer environment, right? So we learn to recognize health cues in ourselves or even in the environment. And then that self-care deficit, the personal care is not meeting the therapeutic self-care. So we, get sick, we got injured, right? Anybody that enters into the healthcare system has some sort of a self-care deficit, right? And then the nursing system is where the nurses empower the clients through the relationships to help meet their self-care demands, right? So we're caring for the client, but we're also educating the client, right? We're also promoting those self-care behaviors so that they can help themselves. Leninger's cultural care theory, right? There's two kinds of care. So we have the generic and we had professional. So generic care, right, was those home remedies that we use, doesn't matter what they are. It could be you have a cold and you're taking, Sudafed and cough medicine. It's whatever home remedies. We have professional care, and that's the care from professionals, right? Whether it's the nurse, whether it's the doctor, whatever, the nurse practitioner, whatever it is. And there's three modes to guiding nursing decisions, right? We have the cultural care preservation or maintenance, the cultural care accommodation or negotiation, and then the repatterning or the restructuring. Um, PEPWA's interpersonal relationships has the four overlapping phases, right? Orientation, that is where patient or the client has a need and they seek assistance, right? So they, have a identified problem and then the nurse is working with the client to help them recognize the problem. Identification, the client understands the situation, they are going to respond to the nurse. And then the exploitation, the client begins to depend on the nurse and will use the help that is offered. And then resolution is that behavior, that dependent behavior is now given up, right? As the relationship becomes to an end. Rosenstock, Irwin tried to explain why or why not a person will take action to prevent or detect illnesses. This was perceptions may not have any basis in reality, beliefs are connected to existing barriers, or acute action is seen as necessary. Tell me the difference between a quantitative and a qualitative nursing study.
Like the quality of the care versus like the amount of care they give.
Say that again, I'm sorry.
Like the quality of the care that they give rather than like the amount of care.
Oh, when you're talking about patient care, no, research studies. When we're talking about research studies, what's the difference between a qualitative and a quantitative research study?
One is objective, the other one is subjective.
Okay, very good. Which one is objective?
The quantitative.
Quantitative.
Quantitative, very good. Yes, your quantitative research studies are the ones that are objective, and then qualitative are subjective. So remember, with qualitative, we're looking at patients' lived experiences. Okay, so we can, it's like, I think that what was the example of that patients living with chronic pain, right? We're asking about their lived experiences. What is the recommended type of quantitative research?
Can you repeat?
The qualitative.
When we talked
Practice?
about, I'm sorry.
Is it evidence-based practice?
So we're in
Would
different,
be
yeah. So when I described the quantitative research study, remember I said there was two types of variables, right? One we have that's receiving the intervention and one that's not. So what's what we call a randomized controlled trial. Okay, so that's the recommended type of quantitative study is the randomized controlled trial. Let's see. And then I want to say with Faith, you brought up can't even say it, quality versus quantity of care, right? So remember, if It's not about the quality, it's not about the quantity of care that the patient's receiving. It is about the quality of care that they are receiving, right? So one of the goals for us as nurses, right, is to keep our patients safe, right, and free from unnecessary harm. Okay, so we want to make sure that we are providing that quality care. And quality care is based off of evidence-based practice, right? So remember, those elements of evidence-based practice is your research evidence, right? Your clinical experience, as well as client preferences. And we're going to take all of those into consideration when we are establishing, right, the plan of care for our patient. All right. So now we have a wonderful case study. So we'll look at our case study. I'm going to share my screen. All right. So here we go. So we have Mr. James Walker. He is an 82-year-old male. He was admitted to the med-surg unit with community-acquired pneumonia and dehydration. He has a history of type 2 diabetes, hypertension, and chronic kidney disease stage 3. He's had frequent hospital readmissions. Mr. Walker lives alone. He has limited financial resources. He reports difficulty paying for medications, and he often skips doses, okay, to save money. All right. So we have 82-year-old male with pneumonia and dehydration. He has a history of diabetes, hypertension, chronic kidney disease stage 3, frequent hospital readmissions, lives alone, limited resources financially, difficulty paying for medications, and often skips doses to save money. So what are some issues right here just with this information?
His main
He's not compliant with medication.
his main problem is pneumonia and dehydration.
Okay. Um, so Okay, so his admitting diagnosis was community-acquired pneumonia and dehydration. All right. He lives alone. He is probably non-compliant with his, and he's not probably, he is non-compliant with his medications. What else?
He's skipping doses to save money.
Okay, skipping doses to save money.
It looks like he doesn't have a lot of resources.
Okay, doesn't have a lot of resources. All right. So here's his vital signs. All right, so temperature is 101.8, heart rate 108, respiratory 26 breaths per minute, blood pressure is 146/88, and his O2 sats are 89% on room air. All right. So 101.8, 108 for a heart rate, respiratory rate 26, 146/88, and O2 sats of 89.
We need to fix his oxygen first.
We do need to fix his oxygen, right? That is definitely a potential issue.
Infection.
Infection. Yep. So he has that pneumonia, right? So yes. All right. So here's his orders. All right. So oxygen at 2 liters per minute via nasal cannula. IV normal saline at 75 mLs per hour. IV antibiotics every 8 hours. Glucose monitoring AC and AC and HS. We're going to put him on fall precautions. And then he's going to have daily CBC and CMP. All right. So, all right. So then the nursing or the unit situation. The med surge floor is currently short-staffed due to several nurses calling out sick. The charge nurse assigns the LPN for clients, including Mr. Walker. So during the shift, a medication scanner is unavailable because the battery is dead. Dietary services accidentally deliver a regular diet instead of a diabetic diet. Environmental Services reports a delay in cleaning rooms due to understaffing. And Mr. Walker states he may refuse one of his medications because he can't afford it after discharge. All right. Okay. So the LPN notices Mr. Walker attempts to walk to the bathroom without assistance. IV tubing is not labeled with the date and time. The client coughs frequently and appears more short of breath. And another nurse states, "We are too busy to worry about small details today." What are some issues here?
They short staff.
Not labeled tubing.
Okay. What could that?
It could lead to a med error.
Okay.
Poor
Um,
patient care.
I'm sorry.
Poor patient care.
Okay.
It's not quality care for the patient.
And it's not safe.
Okay. It's not safe. Okay. All right. So what safety risks are there? So we talked about medication safety, right?
All risk.
Fall risk, no labeling on the IV. So what's the issue with no labeling on the IV?
They could accidentally connect the wrong tube to the IV and start an infusion that didn't need to be started.
Okay.
And they can hook it up to the wrong patient without identifying the name and their birth.
Well, we don't put the patient's names on the tubing. It's usually like the date.
Oh, yeah.
And you don't
And
know when it was last hung up there.
yeah, you don't know when it was last hung up there either, right? So hasn't been, I mean, granted, we probably know because he's only been admitted, but really you don't know how old that tubing was. And that could be, um, that could be potentially an issue. Um, so which problems should we identify first?
Probably
shortness
the
of breath.
I heard someone but say, so which one of these issues should we go to? What should we fix first?
The shortness of breath.
Airway.
Okay, airway first. All right, so we need to address the airway, but we put him on O2 at 2 liters via nasal cannula. But he's still coughing a lot and he's appearing more short of breath. So,
up the O2 or give him ways to manage his breathing better.
Okay. All right. So we're gonna do airway first. Absolutely. What's the issue with the scanner being down?
You can't
You can't
compare the
do
ID bracelet to the medication system.
Okay, so we can't scan the patient, right? We can't link it to the patient, right, within the EMR. or the electronic medical administration record. We can't see, when was his last dose given, so we can't verify that medication through that extra check. What about the diet? How can the incorrect diet orders affect your client or this client?
He has a history of hypertension and he's a diabetic, so he has to be careful what he eats. So if he
Right.
end up getting the incorrect tray, that could cause issues.
Okay. Um, what about his financial concerns?
Social work resources.
Would be referred.
Okay. So how can so we already know that he is non-compliant with his medications, right? And now he's refusing medications because he doesn't know if he can afford them, right? When he leaves the hospital. So social work may absolutely be a potential resource for him, right? Social work can then go out and try to um what's the word I'm looking for?
He could do like
Um,
a reduced payment program.
right. So some of those, like those, what are the pharmacy discount programs that are out there? Um,
Couldn't
if
we
we're
educate him on which Medicare or Medicaid parts cover what so he knows and kind of understands that his medication is covered?
okay, so maybe he doesn't have a prescription drug plan, and maybe that's something, but that we can, right, investigate and try to help them. The readmissions, right? If we're continuously readmitting him, so there's a couple concerns with readmissions, right? Remember that we said if they're readmitted within 30 days post discharge, right, then um, the hospital is going to get a reduced reimbursement, right? It's also going to increase his healthcare costs, right? So that's another, gonna put more financial strain on him. Helping him find a primary care doctor, Alma, that's a good idea, right? Maybe he doesn't have a primary care provider out in the community that can help, right? Because managing his diabetes, right? Where did we go? Managing his diabetes, his hypertension, his kidney disease, right? We can do this out in the community. He doesn't have to go to the hospital to have those managed, right? So if we get that primary care, then, that may help. He also lives alone. And so, what are some, maybe we can try to find some community resources that could potentially assist him. Um, like things like Meals on Wheels, right? Or maybe some, other um, volunteer services. Does he belong to a church, right? Um, look into home health, yeah, that could potentially, if we can discover that he does, if, we can identify that, um, he qualifies for home health, that may be an option as well. Um, let's see. Um, so what can we do for him now to improve safety and quality of care?
Really, I feel like at this point it's gonna be about that therapeutic relationship you've already built with him. And if you've built a good communication with him, then you can tell him why it's important for him to care for himself and kind of tell him what are some things that could happen if he continues down this road.
Okay. Yeah, so lots of patient education, right, is probably super important at this point. But what are some other things like, what are some reminders that we can provide?
Like a weekly med dispenser, um, alarms, little things, notes.
Okay.
Give him like a paper list of the education to take with him so he remembers and can look back on the information.
Okay. Okay.
For safety though, um definitely probably getting new IV tubes or figuring that out and labeling that stuff because that's important.
Mm-hmm. Mm-hmm.
Maybe
Yeah,
a
I
week.
mean, definitely want to um
Would you paper document in this instance where the scanner isn't working? You can't necessarily.
So my concern, I mean, I just have, of course, concerns about paper documentation. We would still, yeah, I mean, if there's not another scanner that we can use, then we absolutely have to document it. And so what at this point, it would be whatever the facilities policy is for documentation. Now, I want to say, what was it? The unit, I have to go back because I can't remember off the top of my head. What was
I
the
think it was
issue?
med surge.
It says a medication scanner is unavailable because the battery is dead. So that doesn't necessarily mean that there is not one, right? There may be one that is available. Not 100% sure. Like I said, it's kind of a vague little statement, but um let's see, go back. Um let's see. Reminding him, I know it sounds kind of, generic, right? But you also want to remind him to use the call bell, right? When getting up and going to the restroom, right? That will help to decrease the fall risks. I mean, if he's in the hospital too, right? We also have the ability to use the bed alarms, right? Or, we could also, if it's something that we're super worried about, then we could also do maybe a urinal, right? So that he doesn't have to get up, or in the event that what's the word I'm looking for? In the event that, somebody doesn't get there fast enough, as much as I hate to say it, um, he has the urinal to use just in case, right? So that's an option as well. Whatever the potential option is. So that would be another potential, safety thing that we can use for patients. Um, I'm trying to think of what else. Making sure that he has everything within reach so that he doesn't try to get up unassisted or try to reach something that, could potentially be an issue. So any of those findings in this here, does any of this require immediate reporting to the RN or the healthcare provider?
Would it be because he appears to be more short of breath, so it's a change in status? So it should be provided to the provider
Say that one more time.
because it's client coughs frequently, more short of breath. So that's like a change in status. So should that information should be provided to the provider.
Okay. Yeah. So this is the appearance of being more short of breath, right? That would be a concern. So providing that information, what are some things that we would be able to help with um the shortness of breath? What are some things that we could do?
Hit them up.
Sit up the bed,
Head of the
Yeah,
bed.
elevate the head of the
Okay.
bed.
Elevate the head of the bed.
Nasal cannula.
Make sure that his nasal cannula is is in place, right? Absolutely. Um,
Would we do some coughing or deep breathing?
absolutely. So it didn't say that he had COPD, right? So that wasn't an issue.
incentive
Um,
spirometer.
incentive spirometer, that could potentially be another option, right? So if we can get him to use his incentive spirometer, even, sometimes even with what do you call it? The word I'm looking for. Um, Even in the absence of COPD, sometimes, right, the pursed-lipped breathing, if they're short of breath, right, may also help them. So that is potentially, right, another option that we can use. Um, what else? I'm just trying to think. But we definitely still want to report to the, appearing more short of breath, right? Because that could indicate, maybe it doesn't say that they put him on IV antibiotics, right? But, how soon is this after the antibiotics started? Are we worried about the effectiveness of the antibiotics at this point, or maybe we need to increase the respiratory interventions, right? What else can we do to help him? So just in general, what are some factors that are going to um contribute to the cost of healthcare?
Readmission.
Okay. The readmission, right? Because he is, if we're continuing to get readmitted, right, that's going to increase his costs. What else?
Worsening of condition.
Worsening of the condition. Okay. What else? Medications. All
More
right.
risk for infection, the more times he has to keep coming in and out.
Mm-hmm. Mm-hmm. All right. Yep. So the hospital readmissions increases um the healthcare costs. The medication noncompliance, right, can also worsen the chronic illnesses, preventable complications, increased length of stay and expenses, right? So we know he's a fall risk already, right? And so if he potentially falls, right, while he's in there, he could potentially break a hip, or, something along those lines, right? So, we don't want that to happen. And then proper discharge planning can reduce future hospitalizations as well. So, you talked a little bit about that as well, right? If we need to, we talked about getting the social worker involved, right? So potentially finding some resources for, medications or, lower cost medications, if we can get him some home health, if we can get him other community resources, as well, right? All of those things may help. And, somebody else mentioned, finding him a primary care provider, right? So all of these things, we can manage his care on as an outpatient, right? Then that's going to benefit him, hopefully, right? So that he does not have all of these readmissions.
I have a question.
Sure.
maybe you already answered it, but if a patient falls in our care, do we eat that cost, or does like that is that just like even if he's been like educated and everything like that?
So, um, it depends on the situation. So if they can prove that we did not meet the standard of care in caring for that client and he falls and he breaks a hip, then yes, the hospital would, if we didn't put certain interventions into place, then yes, the hospital would eat the cost for caring for that, if they fell and broke their hip. If they fell and broke their hip and it is well documented, and this is why documentation is so important, that you've put all the implementations into place, right? You've got the call light, whatever the hospital protocols are for fall prevention, okay? And those were all in place, the constant reminders, all of those things, and the patient still fell. Then that's a different story. They can't really prove that you didn't, provide that quality of care to your client. So, um, that there is that difference. Um, but if it happens and, that's why I say, everybody always says if it wasn't documented, it wasn't done. This is why documentation is so important, even for like um, what do you call it? For like the pressure area, right? Are they are they being turned and repositioned every 2 hours? Are they, staying clean, dry, and intact? Are if they're incontinent, are they being changed appropriately? Right. If we're putting all of because we know that some patients are going to develop pressure areas regardless of the interventions that we put into place, right? Because a lot of it can depend on disease processes and other things. But again, it depends. And the long way to answer your question is really it depends. They have to, they have to be able to look at the nurse's notes and all of the interventions, their care plan, to see if we followed everything that was in place. And if there was any deviation from that, then yes, the hospital would not get reimbursed.
Thank you.
I'm sorry. I did
No,
that
you
the long way
answered it.
around.
Thank you. You answered it.
Um, so what are some examples of quality of care? So what are examples of quality of care?
Educating the patient on using the call light.
Okay, patient education, right? Here's the call late. Make sure if you have to get up to use the restroom, right, that you hit that call bell so that you don't get up unattended and potentially fall. Okay, absolutely. What else?
Is helping them with their ADLs.
Assisting with ADLs, okay? So again, right, they don't get short of breath, that they don't, fall, okay? We'll go ahead and doot. So timely interventions, client education, all right, accurate medication administration, right? This is always going to be a quality care, right? Making sure that they got their medications, infection prevention, we've talked about that. Making sure that our nursing care is evidence-based and that interdisciplinary communication. So with that interdisciplinary communication as a fall prevention measure, who else on the IDT team can we get involved with this patient's care to help us prevent falls?
Physical therapy.
Therapy.
Very good, Shmita. Yup, absolutely. Physical therapy is a big one, right? Because physical therapy helps to improve strength, right? Occupational therapy helps to improve ADLs, right? Putting on socks and shoes and doing laundry and cooking and all that other wonderful stuff, right? So if we can improve his strength and his balance, right, then maybe he won't be as much of a fall risk. So safety issues, we talked about these, right? He's a fall risk. The medication administration without the barcode scanning, that's a huge safety issue. Because let's say, what happens if, let's just say, you're working the unit, you give Mr. I don't remember his name anymore. You give him his medications, okay? And it's not signed off in the chart. And this is just bear with me, okay? So it's time for your lunch break and you go to lunch and all of a sudden now the scanner is working, all right, and someone notices that it's red in his chart. He's like, oh, he hasn't gotten his medication. And then what happens? He goes and he gets that medication, scans it in, and it's gonna scan, right? Because it's not in the chart that it's already been given, and now he's got a double dose of his medication. All right. And with that history of hypertension, oh, his blood pressure was pretty high, but still don't want to double up on that blood pressure medication, right? So there's some issues there. We already talked about the diet order, right? By not giving him the appropriate diet order, then his blood sugars can spike, right? Infection transmission, the short staffing, the unlabeled IV tubing, and failure to respond to those respiratory changes could all be some safety issues. So LPN should reinforce those fall precautions, notify the RN of the worsening respiratory symptoms, verify the diet order, label the IV tubing, use the 9 rights of medication administration, or however, is there still 9? There might be 20 by now. Educate about medication adherence, report the equipment malfunction, and always use SBAR for communication. So you guys hit every single one of those. I mean, I don't think we talked about SBAR, but you guys got all the rest of them. With the labeling of the IV tubing per facility policy, I'm going to tell you what I would do in this situation since I don't know when that IV tubing was hung. I'm going to change out, put new IV tubing, and then label it, right? Because you don't know, was the IV tubing used for the normal saline? Was it used for the antibiotics? You just don't know. So that would be what I would do. All right. So here's a question. Which factors contribute to increased healthcare costs? Hospital readmissions, medication noncompliance, early discharge, teaching, preventable falls, or infection prevention.
All but C.
Okay,
All the
so infection prevention, does that contribute to increased healthcare costs?
No.
no,
Okay.
sorry.
All right, good job. So, yep, so hospital readmissions, medication noncompliance, preventable falls, right? Those all contribute to increased healthcare costs. Which nursing action promotes client safety? Skipping medication scanning during busy shifts, delegating oxygen assessment to unlicensed personnel, following fall precautions consistently, or ignoring the unlabeled IV tubing until the next shift.
C.
Yeah.
See,
Yeah, absolutely. So making sure that we follow those fall precautions consistently. All right. The LPN understands quality improvement when stating A, quality care only focuses on client satisfaction. B, safety and prevention reduce complications. C, costs are more important than outcomes. Or D, shortages do not affect care quality. So which one of those shows that the LPN understands quality improvements?
see,
B.
Very good. Yep. And then which action by the LPN is the priority? So relabel the IV tubing, reinforce the diabetic diet, assess the worsening shortness of breath, or call dietary services.
C.
see.
Assess.
Yep. That worsening shortness of breath is the priority. Good job. That one was kind of fun. I like that one. All right, let's take a break. Be back at 4:20. All right. So I have picked some practice questions. There's I forget what I picked. But I picked all the leadership type questions. This is in the Saunders book. So it'll cover all of the management, um, all of the topics that we've covered so far, here in leadership. So there's like a total of 138 questions. So don't get overwhelmed. We're not going to do all 138, but that was what was available. So I'm going to share my screen. Maybe. There it is. Again, you can answer in the chat or you can, just talk out the answer. Either way is good. All right. So the nurse is planning the client assignments. Which is the least appropriate assignment for the UAP? So 1, obtaining frequent oral temperatures on a client. 2, collecting a urine specimen from a client admitted 3 days ago. 3, assisting a child who is profoundly developmentally disabled to eat lunch. Or 4, accompanying a patient or a client being discharged to home following a bowel resection 8 days ago to their transportation. So which is the least appropriate for us to assign? Need some tiebreakers here. So I have a 4, I have a 3, and I have a 2. And now I have a 1.
3.
I'm sorry?
3.
3.
I got another
3.
couple. I got a couple more 3s. Okay, so we're going to go with 3. Yes, that is correct. So if we look at the rationale, the nurse must determine the most appropriate assignment based on the skills of the staff member and the needs of the client. In this case, whoops, the least appropriate assignment for the UAP would be to assist a profoundly developmental disabled child with feeding. The child is likely to have difficulty eating and therefore a higher potential for complications such as choking and aspiration. The rest are, they're pretty consistent, right? They can do the temperatures, they can collect the urine specimen, and they can accompany a client being discharged to home. So a lot of times, depending on where you work, you may have like a transport person or a UAP that just brings them to their transportation. All right. So the nurse is caring for a client on the mental health unit who has been declared incompetent through a formal legal processing. A guardian has been appointed. The nurse knows that guardians are typically selected from among family members. From the following list of family members, what would be the order of selection of a guardian for this client? So list in descending order of importance from the first to the last choice. So where would the spouse be if we have a client who's been declared incompetent? Where would they be? They would be 1, right? Is that what we all agree? What about parents? All right, so parents, we got a 2 and we got a 3. Got a 2. We got more 2s than 3s. Okay, what about adult siblings? 4. Adult nieces and nephews. 5. Okay, what about adult children or grandchildren? Probably we got a 3 left. So
Adult children should probably be 2.
it should be 2. Okay, so what about parents then? Parents should be
Children, I think it should be
3.
2 as well, and then parents.
All right, so first would be the spouse. Then we got adult children or grandchildren. Then we have parents. then adult siblings, and adult nieces and nephews. Everybody agree? Mix. Good job. Look at you guys. All right. So guardians are typically selected. So order selection is usually the spouse first, then the adult children or grandchildren, then the parents, adult siblings, and adult nieces and nephews. If found incompetent, they may be appointed a legal guardian or representative who is legally responsible for giving or refusing consent for the client while always considering the patient's wishes. In the event a family member is either unavailable or unwilling to serve as a guardian, the court may also appoint a court-trained and approved social worker representing the county or the state. All right. The nurse is completing a medication reconciliation form for a client, which is a primary purpose of this process. So one, to make sure the pharmacy knows what medications the client was taking at home. Two, to make sure the client is well informed about why each medication needs to be taken. Three, to make sure medical insurance companies have a complete list of the client's medications, or to compare the client's medication prescriptions to all of the medications the client is taking at home.
4.
What is the purpose for the medication reconciliation? All right. All right. So 4 is the most common. Very good. Yes. So medication reconciliation is a process of comparing a client's medication prescriptions to all of the medications the client is taking. It helps to avoid medication errors related to omissions, duplications, dosing errors, and drug interactions, and is done at every transition of care when new medications are prescribed or written or rewritten. All right. The nurse collecting data on a child suspects or physical abuse. The nurse understands that which is a primary and legal nursing responsibility. So one, report the case in which the abuse is suspected. Two, refer the family to the appropriate support groups. Three, assist the family in identifying resources and support systems. Or 4, document the physical assessment findings accurately and thoroughly. So which would be the primary and legal nursing responsibility here?
One.
Report.
Okay, everybody has got one. Yes, absolutely. So the primary legal responsibility when child abuse is suspected is to report the case. All 50 states require healthcare professionals to report all cases of suspected abuse. Although documentation of findings, assisting the family and referring the family to appropriate resources and support groups are important. Again, the primary legal responsibility is to report the case. A client asked the nurse to describe the preferred provider organization model of care because the client is unsure of the procedure involved in this form of healthcare. Which statement by the nurse indicates an inaccurate description of this form of organization? So, preferred provider model, organization model. So, one, it provides member services from a selected group of providers. Two, it represents an arrangement between employers and insurance companies. Three, members can commonly elect to see any participating primary healthcare provider without prior authorization. Or 4, beneficiaries are limited to those providers that are participating primary healthcare providers for any required healthcare services. That was a mouthful. So which one would be an inaccurate description of a preferred provider organization? No, it's a mouthful for me. All right, we got 1 and 4s with 4 having the majority. So we'll click 4 and that is correct. So options 1, 2, and 3 are accurate descriptions of the preferred provider organization. In the exclusive provider organization, beneficiaries are limited to those providers that are participating primary healthcare providers for any required healthcare services. If members elect to see any, or if a member is elected to see primary healthcare providers outside the exclusive provider organization, services may not be covered. Good job. Good job. All right. The nurse observes an outburst by a client with a history of schizophrenia, during which the client uses extreme foul language. Which appropriate documentation would the nurse make for this occurrence? 1, document the client is swearing loudly. 2, document that the client is having an outburst. 3, use quotation marks, placing dashes and lines in the place of the profane words. Or 4, use quotation marks, exact words, and additional objective information about affect and nonverbal behavior. All right, let's see, bunch of 4s. That is correct. So, yes, that provides accurate legal defensible information regarding the client's behaviors, right? We want to provide the quotations as well as, right, the objective information. All right. The nurse is told in intershift report that a legal guardian has been appointed for one of their clients. The nurse looks for what evidence that supports this information. So we're looking that a legal guardian has been appointed for one of the clients. The nurse looks for what evidence that supports the information. 1, we have testimony of 3 neighbors. 2, a judicial decision in a court of law. 3, a physician's prescription. Or 4, a nurse's observation of bizarre behavior in the client. All right, we got a bunch of 2s. So we will go with 2, and that is correct. So appointment of a guardian must be done through legal process. It cannot be done by a physician's prescription. Okay, so they have to go through the court in order to become a legal guardian. A resident in a long-term care facility refuses a medication that has been prescribed. The nurse takes appropriate action after considering which fact. So 1, the client cannot be forced to take the medication. 2, the client has now become legally incompetent. 3, the client can be forced to take the medication if the physician prescribed it. Or 4, the client will probably take the medication if the physician personally administers each dose. All right, so we'll go with 1, and that is correct. Yes. Option 1 is true. They have the right to refuse any medication prescribed unless deemed incompetent in a court of law. All right. The nurse is caring for a client who underwent a colon resection and has a Salem tube in place. When a regular diet is brought into the client's room, the client does not want to eat solid food and asks that the physician be called. The nurse persists in the belief that the solid food is the correct diet. The client eats 2 meals and subsequently must undergo additional surgery due to complications. The nurse understands that the determination of negligence in this situation is based on what? 1, the nurse's beliefs. 2, a duty existed and it was breached. 3, not calling the physician. Or 4, the dietary department sending the wrong food. So we have colon under or patient that underwent a colon resection has a Salem tube in place. When a regular diet is brought to the client's room, the client does not want to eat solid food and asks the physician be called. The nurse persists in the belief that the solid food is the correct diet. The client eats 2 meals and subsequently must undergo additional surgery due to complications. The nurse understands the determination of negligence in this situation is based on what? So I've got a 3, a couple 2s, and a 1. Let's see. Trying to get, all right. So if I look correctly, 2 is the winner. That is correct. So proven negligence, remember, requires a duty, a breach of that duty. The breach of duty must cause an injury, and damages or injury must be experienced. So good job. All right. The nurse in charge of a rehabilitation center is planning the client assignments for the day. Which client would the nurse assign to the UAP? So 1, a client on strict bed rest and 24-hour urine collection. 2, a client scheduled to be transferred to the hospital for cardiac catheterization. 3, a client admitted to the center yesterday who has a below-the-knee amputation. Or 4, a client scheduled to be discharged home following rehabilitation for a hip replacement procedure. So which one would we assign to the UAP? All right, we got 1. That is correct. So the nurse is legally responsible for the client assignments, must assign tasks based on the guidelines of Nurse Practice Acts and the job description of the employing agency. A newly admitted client who had a below-the-knee amputation will require physiologic and psychosocial care and initiation of rehab. A client scheduled to be discharged home will require reinforcement of home care management. A client scheduled for cardiac cath requires physiologic needs. The UAP has been trained to care for a client on bed rest and on urine collections. So the nurse should provide instructions to the UAP regarding the tasks, but the task required for this client is within the role of the description of a UAP. All right. The nurse asks a nursing student to describe case management. Which student response indicate a lack of understanding of this about this concept? So 1, it is managing client care by managing the client care environment. 2, represents a primary health prevention focused managed by a single case manager. 3, it maximizes hospital revenues while providing for optimal outcome of client care. Or 4, it is designed to promote appropriate use of hospital personnel and material resources. So which one of those does not describe case management? All right, we got 2s and 3s. Let's go with, I think 3-1, that one. So the correct was 2. Sorry, we got another one coming in. So case management represents an interdisciplinary healthcare delivery system to promote appropriate use of hospital personnel and material resources to maximize hospital revenues while providing for optimal outcome of care. Options 1, 3, and 4 identify the components of case management. All right. You guys did really good. You guys are super smart. Super, super smart. You guys are going to do awesome. Any questions for me? Do these questions help? I probably ask that every time I do them, but I'm going to ask anyway. And so make sure that they are helpful. All right, awesome. All right, guys. Well, I hope everybody has an awesome week. Be safe, take care, have a good weekend, and I will see you all next week.
You too. Thank you.